Go ahead and start trying to keep on the timetable. Welcome back. And we're turning to an issue that I think probably resonates more in the room than the previous one did. That is, we're going to be looking at the efforts to link priorities to the budget process with specific reference to health. And again, we're trying to capture the experiences of partner country practitioners in most of this, so not so much the IFIs or other organizations, but the real experiences of people on the ground. And we hope we have represented these faithfully. They are the people actually speak to you in the case studies. And as before, we see 5 countries that have achieved some successes and then have also struggled with some persistent challenges. And I think at some point in this, somebody's going to pass out to you some cross-cutting bullet points on this. So you'll get a little bit of a sense, we realize you haven't read the short versions or the long versions, but you'll get a little bit of a sense of what they actually did. In this instance, they are mainly trying to introduce better information systems, so financial information management systems. They're trying to set strategic priorities. They are then trying to link those priorities into the work plans of budgets in units. And then trying to develop some sort of monitoring system, so in something closer to real time, they sort of know where they stand. Clearly not all the way down this road, but a lot of these pieces were put in place in the countries of concern in this session. But they all ran into some similar problems as well. And so what we want to profile are the persistent challenges, some of the workarounds that they introduced, and then we're going to open it to discussion from Yuriko Nakamura, who's joined us from R4D and has experience in some of these particular places, but also with an aspect of this that comes up quite strongly in the cases. And again, Salam Fayyad. And then we'll open it to conversation because I know this is an area that more people have experience with. So we, again, are going to begin with a video. In this case, Craig Howsam, who is or has just stepped down as the head of the health department in Western Cape, is going to be talking about the problems or the challenges of trying to follow through on national priorities and to budget carefully at the provincial level. This is something that other South African provinces struggled with very greatly. Western Cape succeeded. He's going to talk about how he thinks they succeeded. This problem that he's talking about comes up in Ethiopia and Vietnam, and to a somewhat lesser degree in Colombia and in Rwanda. So let me start this with the video. And again, as before, this is based on conversations with practitioners in these countries, and I want to thank them for all of the thoughts that they provided here. So let's see if I can get this to run this time. Budgets are management tools. We have all heard those words. And wouldn't it be wonderful if budget processes could help us do just that? Link the sector's priorities to allocation, expenditure, and performance. On paper, the linkages look simple, but in practice, they can be really hard to create and maintain. In 2018, Princeton's Innovations for Successful Societies program sat down with policymakers and civil servants in 5 countries that had all introduced some significant improvements in health budgeting practices and also made progress in improving their health outcomes. Ethiopia, Colombia, South Africa, Vietnam, and Rwanda. We wanted to hear more about the experiences of these governments in using budgets to deliver results in the health sector. How well does budget work as a management tool? In particular, we wanted to hear about the practical challenges that proved especially difficult to address. Because all 5 governments have made progress in improving health commonalities across the case studies. One was the challenge of aligning priorities across levels of government. We usually think decentralization is a good thing. Theoretically, it enables services to match community needs more effectively. However, where some national governments have wide latitude in spending central government block grants, it can be very hard to make progress toward national health targets and goals. The governments in the case study all use collaborative priority setting and training to try to coordinate, but health ministry officials often felt that this practice fell short. Second, in health, most countries have insurance systems managed by separate agencies or firms. The government subsidizes insurance for some enrollees. The way these systems work, whether payment for services or on some other basis, shapes the cost of health care for all citizens, as well as the investment plans of clinics and hospitals. Officials in some countries worry that the incentive systems insurance providers created in their policy undermine the ability to pursue some kinds of national health priorities. Third, some of the sticky challenges these countries encountered were far more familiar. Several found that software for managing expenditure did not integrate with finance ministry systems or with financial information systems subnational governments employ. Introducing a new nationwide approach is often expensive, time-consuming, and error-prone. Few countries were able to link performance information to financial information effectively. Some could account for numbers of people treated for a particular disease, but most other performance information came through separate data collection efforts. And at the clinic level, providing the information often proved difficult for many staff members. Sometimes the problem arose from limited training or from an organizational culture that did not help people see the importance of this task. But often, it arose because the choice menus available did not match the categories staff members thought they needed, or because there was limited internet access. Fourth, finding and retaining civil servants, not only to staff the health system, but specifically to manage financial operations, sometimes slowed the use of the budget as a management tool. Competition of private sector wages or limited focus on the development of these skills lay at the root of many of these challenges. Finally, fragmentation among revenue sources has also proved a challenge for low-income countries. In addition to government revenue, the national health budget has to take account of on-budget donor spending and off-budget donor spending. Often it is hard to know who is paying for what. On occasion, a donor or NGO the government really doesn't know about shapes expenditures at the local level. Rwanda has taken steps to limit this problem. The difficulty remains in Ethiopia.
I think in 2008, clearly, really probably from 2009 with the appointment of the National Health Minister, Dr. Aaron Oxford-Lady, there was a strong move to look at creating a framework from the National Department to look at how money should be spent. That provincial health departments have jurisdiction over 70 to 80% of the money that is allocated, the funds that are allocated for health services. And also important to note is that the delivery of health services in South Africa is the responsibility of the provincial health departments and not the National Department of Health. So that although policies may be defined at a national level, priorities may be identified at the national level, the actual delivery of a health service is primarily responsibility of the provincial government and to an extent in some provinces of the local government or municipalities as we usually term it. So the national minister then embarked on a process through his forum, which is in South Africa known as the National Health Council, where the national minister sits with political heads of each province, the members of the executive council, and the heads of the department and senior officials of the national department, was to develop a series of protocols and policies to define how that budget should be spent at the provincial level. And I think one of the attempts that was developed by the National Department was to say what is a non-negotiable issue. That came somewhat later, but it was an important step to say that at a provincial level, in your budget, what is absolutely non-negotiable that must be fully funded. So for instance, pharmaceuticals, medical consumables, key medical equipment, maintenance. If those are not funded, then clearly health service. From my perspective, seen at a provincial level, the problem was, however, that despite these decisions taken in the National Health Council, in a legislative sense, they are not binding. So that a provincial member of the Executive Council with a responsibility for health services and his or her head of department are not bound to adhere to a decision taken in the National Health Council. They are only bound if it becomes a legislated bill which goes through our national parliament. And that clearly creates a challenge. Remembering that these members of the Executive Council are appointed at the pleasure of the Premier of the province. And if they don't adhere to the views of the Premier of that province, they can be removed. That creates a challenge. And I do remember talking to Dr. Motley about this and him expressing his frustration with the fact that in terms of our constitution, the federal nature, although we are not a federal system, but the federal nature of the way health services are provided meant that other than persuasion, other than using political channels, he could not directly influence the manner in which funds were spent. We in the Western Cape in 2008, 2009, when on a worldwide basis, the financial crunch happened and that government revenues were projected to fall, we then realized that we needed to ensure that the funding that we were allocated was most appropriately spent, and that we had adequate control in terms of that funding, of how we could ensure that the funding that was allocated would ensure the delivery of the services that we had to deliver. The first thing we looked at was, where does our funding go? And in a health department, I think as those in the health sector are aware, it goes to people run the health service. And the key issue is to ensure that we have the right people in the right place and that the salary bill, the compensation for employees was affordable. So the first thing was to introduce a system with my management team to ensure that we had an affordable staff establishment that the personnel had to be put forward. The second thing was to then ensure that the budget that we had was appropriately allocated to the various components of the budget, such as pharmaceuticals, medical consumables, maintenance, infrastructure, etc., to ensure that the people that we appointed had the wherewithal to deliver the health service that the people needed. And in the Western Cape, we adopted a fairly rigorous system to ensure that they happened. And over a period of time, it wasn't initially easy, but over a period of time, we developed a series of systems and processes which ensured that we remained within the allocated budget. I think I want to stress the fact that as a health administrator and a health professional, which I am, it's important to ensure that health gets its fair share. And so my responsibility as head of the health department was to ensure that whatever budget was available, that an adequate allocation was going to health. Because a key realization that came to me and my chief financial officer, whom I must actually credit for the lot of good work that was done, this guy used to be a very competent chartered accountant, is that the ability to control spending is limited at the clinical interface. The doctor or the nurse determines what is spent. And therefore it's important to ensure that we understand what is being spent, where it's being spent, and how it's being spent. And the unit that we created was functional business unit. We involved the clinicians more in how funds were spent and how funds were being utilized. And also that we needed to control expenditure and monitor expenditure on a regular basis to ensure that we stayed, as the year progressed, either if we were targeting under expenditure or over expenditure, that we could effectively adjust it on a regular basis. And I would chair on a monthly basis a financial monitoring committee where we would feed that from all the programs as to how the spending was going. But to do that, we needed the data. We needed real-time, up-to-date data to enable us to make decisions of either to increase spending, decrease, limit spending at particular levels in particular areas within the department. First year, after being appointed, we overspent. For the next 11 years, we never overspent. We stayed within 2% of the allocated budget. And I think it was largely due to the fact that we created the systems and processes which enabled us to effectively manage the budget. Period of my acting as the health department was in the lead proposal. Those were translated into South African health priorities. There were 10 health priorities. And all the provinces, by agreement, in terms of the welfare and our annual performance plans, our 5-year strategic plans, had to speak to and address those. And clearly that was the framework that was set. And that is fundamentally the role of the national development side of it, is to set policy and set strategic direction. Then that is obviously brought down to the provincial level. So the provincial planning would take that as the framework and then begin to address. Then clearly each province is a different dynamic in terms of its disease profile, its burden of disease. So that would be factored in to that development. In my department, we had a senior manager who was responsible for strategic planning, and it was his responsibility then to synthesize that into a provincial set of priorities and a provincial health strategic plan. We had an overarching long-term vision, which initially was named Healthcare 2010, then became Healthcare 2030, and that set, drawing in both international and provincial and national priorities, it set the province on a particular course. Performance-based budgeting is an ideal. I think it's quite difficult. In the beginning, certainly in the initial years that I was a health manager in the Princeton prior to my appointment in the Western Cape, we were involved with structural and other issues, so probably that was not our priority. In the Western Cape, as time went on, yes, it became an issue and a more important priority. And the key issue there is to integrate, as you mentioned, the financial performance, which, as you probably gathered from what I've said so far, was my major focus, and then relate that to where the money is actually going and how you actually link the two. I would say, if I'm absolutely honest, that in all probability, that was not our greatest success in terms of actual performance-based budgeting. Certainly, I think the aim was to start toward it, but I would say that we were not there, certainly, when I retired in 2015. The first thing is to set up the basics of the system that enables us to manage what we have. But the second, next step is to say, okay, what are our priorities? I think in many cases, in the South African context, the health service is just surviving. It's running on almost automatic. The sister in the clinic comes to work every day and sees a large number of people and goes home and says thank the Lord. so the next step is to enable those people to actually have the space and have the ability to do that job properly and to think about it. So once you've got that stability, now you're not just surviving. You're not just wondering where your next health bag or dollar is coming from. You know you have a certainty, and you know what your priorities are, and you have a motivated group of people who are now moving to the next level. Now you can actually start saying, okay, so what are we doing? And how effectively are we doing it? And are we doing it the most effective way we could? And do we have the systems that enable us to know the answers to those questions?
So, thank you. So I'm going to invite Yuriko and Salam forward, and we'll pick up the discussion there. There were a few references that Dr. Hausman made. One was to the general predicament in South Africa, where there was a lot of overspending on personnel at the expense of equipment and materials, and that got some of the other provinces into a real predicament. So hence the particular focus of his comments here. But I'm going to turn it over to our discussants, who are, I think, going to address different aspects of this problem. Eureka.
Great, thank you so much. So I wanted to begin by thanking the organizers for inviting me to speak on this panel, and I think congratulating the ISS program on the development of some really great case studies. And I think I wanted to echo Dr. Salam's point that I think we need more process documentation like this, the sharing of experiences from practitioners. I think that there's a lot to learn from the processes and experiences that really happen on the ground. So I'll be sharing some reflections from these cases as well as from my own experiences on how to link health priorities to the budget process. And I think that there's a lot to cover here, so I thought that it might be helpful to maybe structure my comments around the budget process cycle and highlight some of the key considerations from the health sector's perspective. So starting with budget formulation, I think as Dr. Hausman rightly noted, that for the health sector to be able to actually develop a budget, it's important for them to, I think, recognize what its policy priorities are. And I think one of the most important process-related lessons that came out of the cases clearly for me was the fact that this process really needs to involve different types of stakeholders in a consultative process. So I think in the health sector, this involves involving different actors at the different levels of the healthcare system, starting from the national all the way down to kind of regional and district levels, involving different ministries, so the ministries of finance and maybe some of the other ministries where health does influence some of their work, as well as CSOs and donor partners. And I particularly wanted to, I think, emphasize the point that it's important to not overlook the importance of involving the Ministry of Finance in the planning discussions. And I think the experiences from Colombia, South Africa, and Rwanda, I think all share different examples of how the Ministry of Health and the Ministry of Finance can really come together to I think, break down some of these silos that were referenced in the first panel discussion and to create a more harmonized approach to planning and budgeting so that the two are not kind of done separately. And I actually thought that the Rwanda case had a really interesting model that took this relationship between the Ministry of Health and the Ministry of Finance one step further by embedding finance ministry staff in the Ministry of Health. I think that this was really beneficial for the Ministry of Health in terms of both the Ministry of Health and the Ministry of Finance. I think it enabled them to develop a longer-term productive relationship that allowed for two-way capacity development, I think a mutual understanding of the health issues that are at hand. Another dimension that I wanted to, I think, reflect on that I think came out in the South Africa case study, and maybe is kind of a question to pose to the group, is I think oftentimes the policy priority setting process is a largely political decision that comes from the top down. And I've seen cases where political goals don't always align with what community health needs and priorities are. So, how can governments, reflect those community needs better? Are there ways of, I think, encouraging better public participation to inform the priority setting process? So I think maybe that's a question that I would like to ask this group, and if there's anything to learn from other sectors. So moving on, the next step of the budget process cycle is budget execution. So here, the main goal for the health sector is to ensure that it's using its resources both effectively and efficiently. But I think before we talk about how the health sector can actually use its resources efficiently, I think it's important to consider how the health sector is actually receiving its allocations and how it's receiving its money. So I think historically, many countries, the health sector receives its funding through line item budgeting. And we've seen in countries like Vietnam that are trying to control costs but have line item budgeting, that they're facing constraints due to some of the rigidities that are imposed by line item budgeting. So I know that Dr. Hausman mentioned that it's really hard to actually implement program and performance-based budgeting, but I do think that this is an approach that countries might want to look towards if it expects its health sector to use its resources efficiently, because it provides a little bit more flexibility for the health sector to be able to respond to different needs and to ultimately use its resources more efficiently. So I think in terms of what the health sector itself can do in terms of how it can use its resources more efficiently, I think we're seeing these days that a lot of health financing agencies, national health insurance agencies are beginning to look towards strategic purchasing as a way to use their resources more efficiently. So I think creating the right incentives to encourage the health sector to actually manage its resources well and to make sure that it's going towards priority areas. So by strategic purchasing, which I recognize might be a jargon term that might not be familiar to all of you in the room, we mean that those who purchase health services and medicines on behalf of populations are making evidence-based decisions around questions including what to purchase, from whom to purchase, and how to purchase, so that you're really maximizing the amount of money that you have and making sure that, again, it's getting directed towards your priority needs. And to illustrate what we mean by strategic purchasing, I thought that I could maybe highlight some examples that were shared in the case studies. So the first was experiences from both Colombia and South Africa that were dealing with very high drug expenditures, which is often a high cost driver of health expenditures in many countries, that it recognized that the government could use its public purchasing power to actually negotiate lower drug prices. And I think in the case of South Africa, we saw that resulted in spending on HIV medications dropped by about 50%. So I think recognizing the power that governments, if they are the primary purchaser of services and medicines, do have the influence to, I think, negotiate for better prices and to make sure that resources are really being maximized. In other countries like Vietnam, other strategic purchasing approaches involve, I think, changing the ways that providers are paid and incentivizing, creating incentives so that they're using their resources more efficiently at the service delivery level. I think, again, as Dr. Hausman mentioned, that ultimately health spending really occurs at that service delivery level. So I think it's really important to make sure that you're considering how providers are getting paid, because they ultimately are influencing a lot of the ways that health expenditures are driven. But I think for both program/performance-based budgeting as well as strategic purchasing to really work, I think something that came out really clearly in the case studies was that significant investments do need to be made in building the financial management capacity within the health sector, that you can't just assume that by implementing these approaches that they'll automatically start working, that you really do need to invest the time in training your health ministries, as well as at the service provider level, on how to actually budget and use your resources well. So I think moving to the final step of the budget process cycle, which is budget monitoring, I think the main goal here is for the health sector to make sure that its public spending, that it's being accountable for its public spending. So again, to hold the health sector accountable, I think that program or performance-based budgeting is a promising approach to make sure that you're more clearly tying expenditures to outcomes rather than inputs. But again, I think as I think caveated earlier, for this to, I think, really work, again, I think that the health sector really needs to have strong budget management capacity and basic financial management skills. And I think that as illustrated through the video, the importance of having good data systems that allow you to actually monitor how funds are being spent, and if the flexibility that you're providing through both program or performance-based budgeting is actually resulting in meaningful sector performance and good outcomes. So I think in many of the case studies, a lot of the countries took measures to either create or establish integrated financial management information systems, and I think that that's a really great step, but I think making sure that that's linked to also good health data, that linkage between good financial data and good health data is really necessary for a lot of this to work. And I think finally, just around this point around data use, I think it's not just about investing in the infrastructure. I think people get very excited about new fancy IT systems, but in order for those to get really maintained and for that data to actually be useful, you also do need to think about the incentives that you're creating within the system and the staff within the health sector to actually maintain and update and use that data as well. So I think just to conclude, I think I wanted to maybe leave behind a few, I think, cross-cutting, I think, enabling factors that I think really are important to be thinking about to ensure that health priorities can be better linked to budget processes. So I think, again, the first is investing in good relationships between the Ministry of Health and Ministry of Finance, and I think that that relationship really shouldn't just end at the budget formulation stage, but that needs to kind of be a relationship that is long-term and that there are touch points throughout each step of the budget cycle. I think, again, investing in really good financial management skills within the health sector, so both at the ministry level, but all the way, I think, down to the service delivery level of making sure that your providers know how to manage their resources well. And then I think finally, the investments in good data systems and making sure that the people within the health system are able to actually use that data and that there are incentives to, I think, maintain accurate and detailed data. So thank you.
Thank you, that's wonderful. And I should say, one thing that is not on the tape of Dr. Hausman's comments, but he observed, and others have observed. Daniel Kabaruka, for example, said, a government could spend its entire budget on health. There's no question about that. So you have to figure out what you really want to spend the money on, and then husband that very carefully. And Dr. Hausman made a big case for high performance gives you much greater credibility with the Ministry of Finance. So if you're using your resources very well, you tend to get a little bit more. And I think that's something that one hears in some of your comments as well. But thank you very much. It's a great, wonderful review of what's in the cases too. Thank you. Salam, I'll turn it over to you.
Thank you very much. First, I think governments can do a lot worse with their money than to spend it all on health. And they do. So that's, if I may, with the benefit of the excellent overview that has just been given, elaborate a little bit on the difficulties that Dr. Hausman talked about in doing performance-based budgeting, essentially incorporating health priorities into the budget and all. He focused a lot on the difficulties involved given the system there, the federal system, and the difficulty of really doing what they were doing given the system. So essentially, when you approach a task as difficult as transitioning from line item kind of budgeting or historical budgeting to this kind of more advanced form of it, there are difficulties of all kinds. I'll touch on some of them, but they're complicated and compounded in that context by the nature of the system. And dealing with that goes beyond what finance and what health ministries can do by themselves. Second, I think the point that was made about the centrality in doing all of these things, or the healthy and functional relationship between Minister of Finance and service ministries, key amongst which health in this particular case, education, and what have you, cannot be overstated. I mean, this is absolutely key. And sometimes, as a practical matter, the fact that governments tend to have, generally speaking, a planning ministry complicates this relationship because it is called planning and all, and so if they're not the ones who are involved, then so Minister of Health ends up getting a little bit torn and confused. There are just too many planning discussions, so to speak. Finance is about little else if it's not about planning, to be honest. The budget itself, particularly when it extends beyond 1 year cycle, if it's a multi-year budget, it's a plan, obviously. And so the more developing countries move away from the classic standard ration of having these line ministers as a matter of course, I think the better off and the easier it becomes for government processes to begin to develop and mature in a different way. Diplomatic way, long way of saying the wisdom of continuing to have ministers of planning needs to be considered. I think it's about time, to be honest with you. The planning function needs to be looked at in a different way. Part of the difficulty also lies in the fact that essentially what Dr. Hasman was confronted with is something that policymakers, practitioners are confronted with all the time. They're not really called upon to build something from scratch. I mean, it's akin to fixing a car on the go. They get there and they really see the system, the overruns, under budgeting, etc. And they're called on to overhaul it, but the system exists. And one of the difficulties not talked about here in the transition, and it is dodged often as you make the transition to performance-based budgeting, is what do we do about civil servants? To what extent does performance-based budgeting really take this into consideration? To what extent is that process complicated by the fact that you already have a stock of employees who are there, when you're about to really fix this, with their wage bill, with the wage bill being a significant portion of your overall allocation. So how much faith can we really put in saying what we have, particularly in the early stages, is something that truly reflects a serious effort at integrating public health priorities in the budget framework, which chances are you cannot not pay staff. That's what I'm really trying to say. So if you had the luxury of starting from scratch, no problem. You basically go about the priorities and you ask yourself the question, how many doctors do we need? How many nurses, health workers we need, administrators we need, and you build around that. We don't have that luxury. They're already there. So basically, I think the bridge between the two worlds is yes to move in the direction of performance-based budgeting. It's good, definitely, but not to expect it seriously to yield results overnight or over a couple of years or 3 years, maybe even 5 or 10 years. So I think the mistake that is often made is for there to be the assertion that transition has been made as if it has been completed, when in fact it's really far from it. You get countries really telling you stories about having made that transition, with that being reported on as having been successfully done, with them getting high marks on their PFM, by the way, that they do performance budgeting, when in fact the process is really still driven by historical data, by historical practices, by what really existed, as opposed to what is expected, what's coming forward. So the last point I wanted to make is about purchasing. It is something that in the health sector that's worthwhile all the attention that's been getting, and I think maybe not enough even. And maybe, again, it's related to the fact that these systems are there. It's related to the fact that governments in some countries, in the way they provide the health service, they tended to really actually be the actual provider of the service. Then, some hospitals, private sector starts to get involved, civil society. Different countries have different patterns, different histories. But that the government has a role in the direct provision of service is definitely commonplace. It's there. How do you really do that when it really comes time to actually doing this around the system that is based on purchasing the service? I personally suggest that it'd be really good to really have a competitive system, but to actually look for some kind of an organ, a board, if you will, to really oversee the operation of the system. And to get, you can't really say we're getting out of the system of secondary and tertiary care as government. It's all for these other providers because they're there. Then you really have to think about the interface with insurance. Is it really adequate? Because after all, it's everybody's right, in my book anyway, to have healthcare provided. And if they can't afford it, for that to really be made available to them anyway. That's my own view. You can't really get the government out of the system completely, but you can subject it to the rigor of having to compete, as a matter of fact. And also other private providers to compete. Now, who sets the price at how much? What is, and then how do you deal with revealed preference on the part of significant chunk of your population for a certain provider or providers over others? That's why you need probably that other layer in the bureaucracy in order to ensure that the process is kind of really well managed. Thank you.
Very good. Thank you very much. So many thanks to both of you. We're going to open it up to questions or comments, observations of things you have seen. You can throw anything at our panelists. Anybody has observations?
Thanks for the interesting comments. It's Maya King from the Blavatnik School of Government, University of Oxford. Just wanted to say about performance budgeting. I don't know if it's necessarily kind of the next step. It's not always a solution to everything. You know, we can move beyond line item budgeting without necessarily going to performance budgeting. I mean, they're kind of different objectives, really. We can think about delegated expenditure limits in the UK. We haven't had any kind of performance management system, really, in the last several years. So, you know, if line item budgeting is actually about fiscal control, expenditure control, then you can have other ways of doing that without doing performance budgeting. So I think it's about different objectives at different times.
Salam, you want to reinforce that?
Very good to hear, thank you. I was trying to really contain in my kind of assessment of how often this is really so central in what is expected of developing countries to make the transition and all. And I often say, well, ask the providers of that advice if their own countries are actually doing that. Ask if the IFIs themselves are actually doing it really, and then let's just really talk about it. But really, again, things evolve, without really wanting to really be too extreme on this. That's why I suggested maybe it's kind of really a good transition to make, but I think it really is not a good idea for there to be the expectation that that transition can be done or handled in a smooth or certainly not a fast way, that one really has to build into that transition steps that take into account the various complications in a serious way. As a matter of fact, it's an outcome that, in my way of thinking, kind of really emerges as opposed to happens. As a product of, while you're doing still the line budgeting, making the process a little bit more rigorous in terms of really actually asking questions as to why do we have this, why do we have that, and then move to the next budget cycle. So over time you could get there. But unfortunately, yeah, it's thought of as this magic tool that is going to really look after the kids when you go to the movies, and it isn't. I think countries would be better advised to spend resources on, for example, the purchasing issue, how to really manage that, right? Because it begins to answer important questions about the role of government in the direct provision of service, and how to really handle it, how to upgrade it, and how not to bankrupt the private providers. Because if the price is set in kind of too low, then these guys are not going to be in business that long. This is a lot more profitable area of focus, I think, as you think about health care reform, including insurance, than performance budgeting. Thank you.
And I think you bring up a really valid point, that I think that just because something works in one context does not mean that you just go ahead and take it into a different context. And I think the point that you made, that you first, I think, really need to know what your objectives are, and then you build the systems around that, I think is a really great point. And I think that oftentimes we sometimes do want to make generalized comments that, you know, like performance-based budgeting is kind of the direction to move. But I think when bringing this to countries, it's always, I think, really important to ground it in what's actually happening in the country, what its priorities are, and I think build solutions around that, rather than, I think, bringing in these, I think, generalized, I think, approaches and solutions to countries. So I think just a point to say that totally recognize that like something that might work in one country is not necessarily the solution to another country's problems.
Other issues?
Hi, my name is Moritz Piatti. I'm an economist at the World Bank in the health group. I have a couple of comments. First, I think, following the remarks from Dr. Hausman, I think it's very thoughtful to think about the provider, the role of the health facility. And in many countries that we work in, the provider is simply not recognized in the chart of accounts. Right? So it's the district that's the lowest entry point. It's the district that has the financial management information system. It's the district that executes the budget. Then the district passes, the district purchases and passes those things on in kind to the facilities. Right? And in this kind of situation, I think it's very difficult for the facility. But there's an accountability gap because the facility provides the services, but the district does the financial management. Right? And in this kind of an environment, I think you can't really talk about purchasing because there is not really a relationship. And the second comment is also on purchasing. I think we have somewhat of a lacking conceptual clarity of how purchasing actually fits into the budget cycle. Because with purchasing, conceptually from a health economics point of view, right, you provide, it's about how the health facility is being paid. Right? That can be on a fee-for-service basis, it can be on capitation basis, and so on. And there are performance-based financing initiatives happening all over Africa. And that is paying or providing resources to the health facility on an ex-post basis after the facility has provided services. In the PFM cycle, in the typical budgeting cycle, the facility gets a budget allocation in the beginning of the year. Right? And that is fundamentally different. And I was wondering whether you could speak to how one can conceptually reconcile these kind of issues, or how purchasing fits into budget execution, which is something that you have alluded to, which is actually a bit unclear to me, because to me the budget execution is about, how, it's the point of execution, whereas with purchasing, I think it's about how a budget is being allocated to the facility. Lastly, and very, very, very briefly on the financial management information systems, I think if we're thinking about this dual function of a PFM system that should provide on the one hand fiscal control, aggregate fiscal control, and on the other hand facilitate service provision, I think it would help us to think about what items in the budget constitute a real fiscal risk and should be controlled on a line item basis. Right? And financial management and an IFMIS system should do that, right? It should control. Then when we think about service provision, and IFMIS should also control, but perhaps from a service provision perspective, more flexibility is necessary because you can't perfectly predict what is needed at a point of service delivery. So, I think it would be helpful to think about a risk-based approach, right, where you think about what is it that we really need to ensure that the PFM system facilitates fiscal discipline, and where is it that the PFM system needs to facilitate more flexibility. And I think the way that we deploy IFMIS system can play an important role. Thanks.
So I can maybe speak to the kind of purchasing and PFM question that you raised. And I think the health sector is very unique in the sense that there's a lot of unpredictability in expenditures, more so than I think other sectors. And I think I totally agree with you that, especially when you do have a fee-for-service-based payment where you're paying providers after the fact of the services that they've provided, it's very hard to, I think, control costs and do some of that budget management. So I think, especially with a lot of these strategic purchasing approaches at the provider payment level, a lot of the shifts is actually moving towards paying providers for a kind of either a bundle set of services or paying providers a set amount per person, so that there's a little bit more predictability in how much money is actually going to the providers, and then it's really up to the providers to really manage those resources themselves. So I think some of the shifts towards things like capitation or diagnostic-related groups is, I think, one way to allow for more predictability of health expenditures. But I think that kind of tension between the unpredictability of health expenditures and what to do around kind of budget management and budget execution is I think, a particularly, I think, difficult topic that a lot of us, I think, in health really, I think, grapple with. So.
By its nature, as you know, obviously, budgeting is good measure projecting. And given the high unpredictability of health expenditure, there is that problem in particular. One way in which budgeting can take care of exigencies, things that are not expected, anticipated, and all. I mean, if you over budget, it's okay, so long as you really actually do what you have budgeted. But the problem is when you run out. Essentially, that's what we were talking about. That's the inconsistency or apparent inconsistency. Since it's projection, you could be wrong, and that's why, as a matter of fact, this business of suggesting that performance budgeting is totally detached from an assessment of existing patterns or historical patterns is too contrived. Not even with that, you still could make a mistake, obviously, and you could end up under budgeting, and you simply cannot allow somebody to go uncared for because you don't have the resources. Hence the insurance, as a matter of fact, depending on what kind of insurance scheme you have, that's a mechanism in which societies, governments, countries try to deal with this uncertainty. The country as a whole could be facing a problem of lack of sustainability beyond the government itself because of miscalculation and all of that. But one way in which you can deal with this is to allow agencies, including, I would say, especially the health ministry, to have as part of the budget a bit of a cushion. That's a reserve. It's a line in budget, for sure. That is not budgeted ex ante specifically for this, that, or the other thing. A certain amount of money that history tells you is enough to deal with emergencies as and when they arise. But so long as you have this problem projection, you can argue your point that there's going to be this problem between managing ex ante and managing ex post, but there is no going around it. But
So we have till 2 o'clock? 1:45. Oh, we're over. Apologies then. We'd love to hear more from you. And maybe is this a coffee break or is this? No, we're going straight in. Okay, we're going straight into the next session. So after the next session, I think we'd be happy to talk further right outside the door in the lobby. Thank you very much. Thank you very much to both of our speakers. Eureka.